On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Nasogastric Tube Placement Verification, Implementation and De-implementation Strategies. My name is Susan Wallace, and I will be your moderator for this program. We welcome any comments or questions, and all materials are provided for your educational use. Now I'd like to introduce our speakers for the webinar. Dr. Lea Anne Gardner is a patient safety analyst with the Patient Safety Authority. She has 30+ years of research experience in patient safety, performance improvement, cardiology, and behavioral health. Dr. Gardner is a member of the Patient Safety Movement Foundation Nasogastric Tube Placement Verification Workgroup. Her most recent publications focused on nasogastric tube misplacements and placement verification. Beth Lyman is a nurse with 4 decades of experience in adult and pediatric nutrition support nursing. She retired from Children's Mercy Kansas City in 2019, where she served as the Senior Program Coordinator for the Nutrition Support Team. Beth is now a consultant and remains an active member of ASPEN. She is the chair of the Novel Project, New Organizations for Enteral Tube Location, which is an inter-organizational, interdisciplinary, international effort to define and disseminate information regarding nasogastric feeding tube placement verification in infants and children. Ms. Lyman discloses a consulting relationship with Avanos and Alcresta. Dr. Sharon Y. Irving is an associate professor and vice chair of the Department of Family and Community Health at the University of Pennsylvania School of Nursing. She has a clinical appointment as a nurse practitioner in the departments of Nursing Clinical Care Services and Critical Care Medicine at the Children's Hospital of Philadelphia, where she maintains clinical practice in the pediatric intensive care and progressive care units. As a PICU provider and nurse scientist, Dr. Irving has focused her work on nutrition therapy in critically ill infants and children. This includes obtaining an interpretation of accurate anthropometric measurements, determining energy and protein requirements, optimizing nutrition delivery, and monitoring tolerance of enteral nutrition in this population. At the conclusion of this webinar, participants will be able to identify nasogastric tube placement verification methods used in Pennsylvania healthcare facilities, apply concepts of de-implementation science to NGT placement verification, and discuss the Novel project to identify best practices for NGT placement verification based on current evidence. Lea Anne, I will now turn the program over to you.
Thank you, Susan. Good afternoon, everyone. My presentation focuses on research Susan Wallace and I did on nasogastric tube misplacement and verification methods. We will start with why examine NG tube placement verification. We know it is important to verifying the location of an NG tube after insertion to prevent causing patient harm, such as aspiration, perforation of the lung, or esophagus from misplaced tubes. Before we discuss verification methods, I want to discuss NG tube misplacements identified in a study of Pennsylvania hospitals. Susan and I queried the Pennsylvania Patient Safety Reporting System, also known as PACERS, to identify reports describing misplaced NG tubes that occurred over a 3.5-year period. Our review identified 197 reports describing misplaced nasogastric tubes. Over 80% of the reports came from acute care hospitals. As you can see, 70% or 139 reports identified an NG tube that ended up in a patient's lung. 80% of these 139 reports indicated an enteral feeding tube or a small bore tube was inserted. And in 84 of these 139 reports, a patient developed a pneumothorax. Here is a Sankey diagram that was from the data snapshot article. It shows the information described in the 84 reports where a pneumothorax occurred due to a misplaced tube in the lung. It shows the relationship between the size of the NG tube, which is the left-hand side of the diagram, and the intervention treatment, which is the right-hand side of the diagram where treatment was administered. The color-coded boxes on the left and the corresponding lines represent the size and type of tube. For example, the color-coded blue box represents small bore enteral feeding tubes. The thickness of the lines is proportional to the number of reports underlying each specific relationship. So you can see that on the small bore feeding, the thick lines at the top of the diagram show the largest number of reports identifying patients diagnosed with a pneumothorax that had a chest tube inserted to treat that pneumothorax. Now, normally in this type of diagram, the boxes would be the same size as the lines. However, you will notice that some of the boxes are larger than the corresponding lines, and this was done to be able to facilitate readability and therefore does not reflect the actual number of reports. So let's move on to learning about accepted NG tube placement verification methods. In the second article that Susan and I wrote, it focuses on NG tube placement verification methods used in Pennsylvania hospitals. We use the same 3.5-year period used in the misplaced NG tube data snapshot article, but in this article, we identified 599 reports describing NG tube placement verification methods. These reports were divided into two groups. The first group contains reports that identified the use of best practices, otherwise known as evidence-based methods. The second group of reports identified the use of at least one non-recommended verification method. We are going to spend a few minutes discussing what are best practices. The best practices identified in the reports are X-rays and pH aspiration testing. As you can see, most of the reports identified the use of X-rays. But while we've identified best practices in these reports, you can also we also have room for improvement in where doing these types of best practices. When reviewing the verification method reports, one of the issues we identified were policy issues associated with X-rays. So X-rays are used to visualize where the tip of the NG tube is located. Chest X-rays help verify whether the tube is in the lung or not. However, the tip of the NG tube is not always seen in a chest X-ray, and there are chances where the stomach may not also be visualized in the X-ray. So it makes it impossible to verify the tube's location. When this happens, another X-ray is needed. There were reports describing confusion about which type of X-ray to order to confirm location. The literature does not identify a specific type of X-ray, so they don't identify having a chest X-ray versus an abdominal. The goal, however, is to have an X-ray that can visualize the tube's location, including the tip. Another policy issue concerns staff proceeding with starting enteral feedings and administering medications prior to verifying the location of the NG tube. This activity is risky, especially if the tip of the NG tube is in the lung. The introduction of enteral feedings or medications can lead to an aspiration event. Now, the final policy concern I want to discuss today focuses on a medical condition called ataxia telangiectasia. This condition is rare and affects the nervous system. Signs and symptoms usually begin in early childhood. People with this condition are very sensitive to effects of radiation exposure, including medical X-rays, and they are at increased risk of developing cancer. This becomes important since X-rays are considered the gold standard in the U.S. for checking NG tubes. Another issue arose when best practice verification methods occurred were communication issues. I'm not going to discuss all these, but I just wanted to point out we identified 6 issues that represent communication gaps in coordination of care that can lead to inconsistent care delivery and possible poor outcomes. Now I'm going to discuss non-recommended NG tube placement verification methods. These are methods that are ways staff verify NG location, but the methods are not approved for use. Now, we found that there were 9.2% or 55 of those 599 reports identified the use of non-recommended NG tube placement verification methods. For purposes of time, I'm going to focus just on the first 2 non-recommended methods in this bar chart. The first is air bolus auscultation. This was a method of NG tube verification I was taught in nursing school. And what it amounts to is it's performed by injecting air into the NG tube while having a stethoscope over the stomach. When the air is injected, the sound is supposed to be an indication of the NG tube location. Now, Matheny conducted a study in 1990 evaluating a clinician's ability to determine the location of the NG tube based on taped auscultation sounds. Overall, her results identified the average percentage of correct classification using this method was 34.4%. And even with this information coming out back in 1990, the verification method is still being used today. Due to the low reliability, this verification method is no longer recommended for identifying NG tube placement location. The next frequently identified non-recommended method that we found in our reports is not implementing a verification method or documenting the method in the medical record. Every NG tube that is inserted needs to be verified, and the method of verification needs to be documented in the medical record so subsequent staff know when the last time the NG tube placement was verified and how it was verified. Now, this slide is to show where the reports of non-recommended verification methods happened. As you can see, acute care hospitals have slightly more reports than children's hospitals, and long-term acute care hospitals have the lowest percentage. We then analyzed the reports of patients less than 1 year of age. Given that this age group had the highest percentage of reports identifying non-recommended verification methods, we found a statistically significant difference in the percentage of reports identifying non-recommended methods in patients less than 1 year of age when compared to all other age groups combined. So in conclusion, our study identified the use of non-recommended NG tube placement verifications and a statistically significant difference in the percentage of reports for patients under 1 year compared to all other groups when looking at non-recommended methods being used. We also identified risk reduction strategies. However, I will not discuss these strategies because we have Dr. Sharon Irving who will be discussing some of these methods later in the webinar. Beth, I will now turn this program over to you.
Thank you. to the organizers of this webinar for giving me the opportunity to speak on the process of de-implementation. It is clear to those of us trying to promote best practice as it pertains to NG2 placement verification that not wanting to let go of tradition-based practices of auscultation or visual inspection of aspirated fluid is blocking progress. In the next few minutes, I hope to delineate why nurses seem resistant to letting go of ineffective methods to verify NG2 placement. These are my disclosures. Now, on this slide, there are many questions that we need to ask when it comes to any kind of practice de-implementation, but I'll focus on a few. Is that practice in questions identified as safe and effective? And if not, why are we still doing it? How do we identify procedures that are do not do? In other words, stop doing them, they are not effective or they're low value care. How do we break ingrained but time wasting and ineffective habits? And for those of you in the clinical world, we have a lot of those. And then if the strength of evidence is not sufficient to abandon an ineffective or unsafe practice, what other measures can and must be taken? So there are many definitions to de-implementation, but these are some of the ones I found in the literature that I think are particularly helpful for this talk. It's a creative deconstruction. In other words, literally just getting rid of something before implementing a new practice, and sometimes they actually have to be simultaneous. Ending practices that are proven to be harmful, overused, or inappropriate is another germane type of definition. And then finally, reducing low value care to replace high value care processes. So, de-implementation science first appeared in the literature in 2006, but implementation science has been around for a long time. Both use change theories, but in a different way. So in de-implementation science, we really have to convince staff to stop doing something that they perceive has always been done that way. It uses kind of counter conditioning methods, such as rewards for not doing a procedure or a process, and often, almost always, requires administrative support. And in this particular science, because it's relatively new, outcomes are often lacking. These are some examples of de-implementation science publications that are research that's out there. You could probably name quite a few more, but these are just some that I found in the literature and even in my clinical practice. So there are strategies that we can use to de-implement a process that we no longer want nurses to do, or any healthcare profession for that matter. This is not just the nursing profession that's been involved with this. So we can essentially replace a current practice with something that is considered to be superior, more effective, either that or it's more time efficient or it costs less. And so Lea Anne did talk about how we need to replace the use of auscultation with something that's more effective. So you'll be doing that at the same time. Or removal of a practice that's deemed ineffective, harmful, or not cost effective. We also need to reduce sometimes the frequency of something that's used. I gave a couple of examples here. Measurement of gastric residual volumes is one. And then restricting or defining who can do a procedure, such as indications, defining who it's indicated for. So some of these things would be like the delivery of conscious sedation. I had to take a course in order to do it years ago. Putting a PICC line in, same thing. Use of a device such as the CORTRAC to place an NG tube. Many institutions now are limiting who can do that based on if they've completed a competency. There are also a lot of contextual factors to consider. In other words, the noise that isn't really easily out there, but it's going to trip us up if we don't keep it in mind. If there is administrative support and unit-based champions, now perhaps not on every unit, but on some key units, then the changes, the de-implementation is apt to be quite a bit more successful. Depending on the institutional history with the practice. Have they had problems with this practice before and now it's just time to stop doing it? And also, what's the possible economic impact? And I'll talk about that in a couple minutes. Then we have the individual nurse factors. And for many institutions, we are very dynamic. A lot of things are changing. We expect nurses to do different things all the time, and they get tired with that. They really do. So then they become resistant to just plain change, or they become resistant to something that was not taught by them in nursing school. As Lea Anne said, she was taught auscultation 30 years ago. I was taught it 40 some odd years ago, about 45 years ago. And then this is kind of difficult. If the nurses or a nurse is not convinced that the practice that they're doing now is unacceptable or should even be changed, why should we do this? We don't have a problem with it. Now, this bottom one is probably going to be one of the key barriers, and that is if there's a single influential nurse on a unit that views the practice to be de-implemented positively or negatively, that could impact the unit. So these are some of the concepts that I want to go through individually. So, acceptability. Is the practice acceptable that we want to de-implement, or is it no longer safe, effective, and effective? So the key thing here on this slide is the practice itself or the idea of stopping the practice a barrier to de-implementation? You see there's a difference. Look at these quotes. I know I need to verify NG tube tip placement, but I've never had a problem with using auscultation. I was taught to use auscultation to verify NG tube placement in 1990. We come back to this, and I'm going to do what I was taught in nursing school. And sometimes, not always, but sometimes nursing education does not keep up with things that need to be de-implemented. And is the practice to be de-implemented no longer appropriate given the current evidence? Again, this goes back to the issue in the former talk of best practice. Well, what if you have someone that says, but we don't have misplaced NG tubes in this hospital? So how a staff nurse or a charge nurse or someone that is not privy to big picture issues would be able to say that? I do not know, but I've heard this said to me many times. And then down below, who defines what appropriate practice is? And we get this one a lot too in the novel project. pH measurement may be fine for other nursing units, but it is inappropriate in the NICU. In fact, we're kind of dealing with that one right now. And then we have the cost or the perception of cost. So is the procedure that we want to de-implement less cost effective than what will replace it? And sometimes that's not the case. Sometimes actually we want to de-implement something because it's ineffective, but what we replace it with will cost some money. Is the procedure to be de-implemented less labor intensive? So now look at this quote. What I do now with auscultation costs nothing, but pH strips are expensive and I have to go around trying to find them. That takes me more time. So now let's break this one down, because auscultation doesn't cost anything in terms of anything other than the nurse's time. But the key thing is pH strips are very cheap as well. So the key thing to focus on here is I have to go around trying to find them. The key is make these supplies easily available. If we're going to de-implement a practice, when we implement a new practice, the supplies need to be readily available and easy to find, because nurses do not want to do something that takes more time. And then we have to always look at the human cost factor. for de-implementing a practice. So if we use pH in place of an X-ray, it will save radiation exposure and it will allow us to feed the patient sooner. This is well documented in the literature, particularly from the National Health Service in the United Kingdom. The cost of pH, paper, or strips, or whatever people use to validate NG2 placement, even an X-ray, is offset by the risk of one misplaced NG2 with patient harm or possibly death. So penetration, how well can the institution get this practice de-implemented across all practice areas? And again, the NICU comes up, and then also home care. And this involves messaging from patients and staff to patients and staff, and getting medical staff involved and supported. So sustainability, how likely can we sustain this de-implementation? That's a very important thing. But if we alter workflow, such as taking auscultation or aspiration off the electronic health record where the nurses document how they verified NG2 placement, that should help. And then again, making sure that whatever we implement, the supplies are there. Another one, counteracting forces to undermine efforts to discontinue a practice. I bet there's no one on this call at all that has tried to change a practice and not come across a couple of key people that want to undermine the progress. So a well-respected charge nurse speaks out against cessation of a practice and openly admits that she or he will not follow the new procedure. That absolutely must be addressed with that individual right away. So there is a process to de-implementation. Obviously, whatever the practice that needs to go away, it is identified oftentimes because of event reports. And I'm sure that there are many people on this call that look at event reports on a regular basis. And so that's the beginning oftentimes. And then an evaluation of what the current practice is, what is the evidence in context to what we're doing now. In other words, what's the evidence say, what are we doing, and what's our history with this whole practice area. Identifying barriers and then facilitators. So you want not only to identify what's going to work against you, but you want to find people who are well respected within the organization and on some of the key nursing units to help with the de-implementation. Design the process, communicate it, and then evaluate it. So the first thing to do to set the culture for its success is to get a vision, a shared vision of whatever that low value care or outdated procedure is, and then get resources, get a work group together and resources to identify the best way to de-implement the process. The focus groups will start a conversation about detriments for the use of the current practice and find out what people's thoughts are right at the bedside where patient care is delivered. And I'm not saying doing this in a patient room, I'm saying get bedside providers to tell you what they think about the practice that's currently being done that needs to be de-implemented. And then messaging about the potential for patient harm if the status quo continues. And then data sharing about how many events in a general way have happened, things like that. So, do you know this nurse? Because I bet you probably do. I can be really stubborn. This came from a study. So if it works really well, I don't want to change my practice. I would really depend on what the practice was and how compelling the evidence that was given. So you need to tell me why I need to do this. I'm not going to do it just because someone says so. It's a very sad comment, but very indicative of many, many nurses. And I'm not going to go through these slides, but I want to have them for you as an opportunity for you to see that it's not just nursing that has difficulty letting go of practices. All healthcare disciplines can struggle with that. Now, this study was done on this very topic of de-implementation. So I want to go through this. It was a convenience sample of 408 critical care nurses at an American Association for Critical Care Nursing meeting. And they were asked how they verify NG2 placement. Look at this, very depressing. 76% still use auscultation. 88% said that they had seen a colleague use auscultation. 72% said that they knew about the AACN practice alert on NG2 placement verification, which absolutely recommends against using auscultation. And only 22% used pH measurement. Now, these are bedside methods, so while an X-ray was probably done on many of these patients that were taken care of in an adult critical care area, they did not ask about X-rays. So the take-home messages from this study is that, from the authors, this was a post hoc evaluation of the data. Nurses that saw someone else, another nurse, use auscultation were 4 times more likely to use it themselves. Nurses who work in a facility that bans auscultation are 31% less likely to use it. And there was a perception that other methods, such as pH, to verify NG2 placement was no better than auscultation, so why change this age-old practice? So the authors recommend an effort at targeted de-implementation of auscultation in order to abandon this ineffective practice. So in summary, the term de-implementation is relatively new. The process of trying to cease an ineffective procedure to improve patient care is not new. We've been trying to do this since I was in nursing school. De-implementation pertains to all healthcare professions and really in all healthcare settings. It's not just the opposite of implementation science, and it really requires targeted efforts in order to be successful. And now I would like to turn the program over to Dr. Sharon Irving.
I have no financial disclosures. I do have some internal funding from both University of Pennsylvania and Children's Hospital of Philadelphia. So to take all the information that my colleagues have presented to you today, I want you to put some things in perspective. So one of the things that I want you to think about is how many times you have placed an NG tube or have helped a colleague to place one. How many times did you have a question in your mind with that placement as to whether or not it was in the right location? And then think about, with what Beth and both Lea Anne have just said, what was the method that you used? What's the standard in your facility for placing NG tubes, and is that different in different units within your facility? And then lastly, have you ever cared for a patient following an adverse event that was directly related to a misplaced NG tube, or were you that person? So I want you to keep those things in mind as we go through the rest of this. There we go. So the background and the scope of the opportunity. So I just wanted to give you an idea as to what we're dealing with here, right? So approximately 10 million NG tubes are used annually in Europe. And here in the US, roughly about 1.2 million. A 2016 study that I'll go through a little bit later, but it reported about 24% of US hospitalized children will require a nasogastric, an orogastric, or a post-pyloric tube during their hospitalization. So just take a couple seconds and think about, what is the admission rate in your own facility? And if 24% of them are going to use an NG tube, you can see where these numbers come from. Of that 24%, that study that was done in 2016, we were able to identify that 61% of that number are patients in the NICU. So our most vulnerable, our youngest, and our smallest are at highest risk because they get them more than anyone else. So with that background, we are pushing an annual growth rate of nasogastric tube usage to exceed $474 million by 2024. So all that to say, an opportunity exists for us to better understand, better direct, and to develop universal best practices and guidelines for the use of NG tube and NG tube safety. So why do we use NG tubes anyway? They're easy, right? and it's an easy way to access the gastrointestinal tract, particularly for patients who, for whatever reason, cannot take foods and medication and fluids orally. And there's an increased demand of them these days. We use them for enteral feedings, we use them for fluid delivery, we use them for medication administration. We also use tubes for gastric decompression. And I have that written differently to emphasize the fact that it's a different type of tube, but it still puts our patients at risk that the tube can be misplaced or displaced. And there is no one patient population that has the cornerstone on this. This is across the lifespan. So our youngest patients to our oldest patients, to our elderly, to our most fragile, to our critically ill, all use nasogastric tubes. So it's a frequently used device. Many of you on this call will know that. We use it all the time, and we don't think about it very much, but it's blindly placed. And what that means is we, as nurses and other healthcare providers, will place those tubes without direct visualization of where we're going. So that's one of the challenges that we face when we talk about nasogastric tube safety. Other things that come into play are the patient age, the size and weight of the patient, their ability or not to cooperate with placement of the tube, and what is their degree of illness, and how does that play into that tube placement. Think about the proximity of the esophagus and the trachea. They want one lays on top of the other, right? And so therefore, the ability to place a tube erroneously, again, high risk. And when you go back and think about the ability of the patient to cooperate and their degree of illness, that may increase the risk when you think about proximity of the esophagus to the trachea. There are various methods out there that we look at and we use for determining the depth and how far does that tube need to be, right? Because again, we're placing these blindly. So in pediatrics, for example, we use things like the NEMU method, where you go from the nose to the ear to the space between the end of the xiphoid process and the umbilicus. But is that the only way to do it? No. There are places that still use what we call the next method, which is the nose to the ear to the xiphoid process. Studies have been done that show that next method, particularly in children and infants, can leave a tube high, so a displaced tube, okay? And then there's some studies out there that look at age-related height-based in terms of a method to determine tube depth, and that is more in our infants and younger populations. And the jury is still out as to whether or not that is the best way to do it. Another thing that comes into play when we talk about the challenges is the fact that there are discrepancies on a standard for NG tube location verification. Now, you've heard my colleagues talk about radiographs being the gold standard, but you also heard Lea talk about the fact that do you get a chest x-ray or do you get an abdominal x-ray? And there's no standard for that. Nor is there a standard for how those films are ordered so that the reporting back from radiologists may be different and variable. So again, we run into challenges as to verification issues. And there's no national reporting mechanism or requirement for this. Going on with the challenges. What's in the literature? So there was a single-blind randomized controlled trial that was done in 2014 of 276 participants, and they found 23% of NG tubes were misplaced. 15 case reports were found in 2013 of children with NG tubes located in their pulmonary bed. And then in 381 neonatal radiographs that was done in 2008, 59% demonstrated nasogastric tubes were misplaced. And the largest study that we've been able to see to date in more than 2,000 nasogastric tube placements granted in adults found 1.3 to 2.4 misplacements. So if you do the math, you're talking somewhere between 400 and 480 misplaced nasogastric tubes. Now, out of 2,000, that may not seem like a lot, but one misplacement is too much for that patient, that family, that nurse, that provider. So both of my colleagues have mentioned practice alerts, and so this one was put out by the American Association of Critical Care Nurses in 2010, and I want to bring your attention to the fact that they recognize that these tubes are blindly inserted, and it's often considered an innocuous procedure, but blind placement puts patients at risk for serious and even fatal complications. So what do they recommend? A variety of bedside methods, a radiograph, and location checks at least at 4-hour intervals. The Child Health Patient Safety Organization put out a patient safety alert in 2012, and they recommended immediate discontinuation of use of air bolus. And you just heard Beth talk about, we know that nurses are still doing that. They also said discontinue use of that next method that I mentioned because those tubes can be misplaced. And then lastly, they recommend using an X-ray. So we as healthcare providers, what's our goal? What vow do we take as we become these healthcare providers, be it nursing, medicine, or any other provider? First, do no harm. And so what this is depicting to you right here is that there's an enteral tube that was placed and it went to the right lower lobe. This one here, as a result of this, has a pneumothorax. So there's differences in a misplaced and a displaced tube. A misplaced tube is when that device is placed and it ends up anywhere other than the intended location. And then a displaced tube is that tube that was in the intended location and is removed from that location. So there are reports of these displacements and misplacements being in the brain, in the small bowel, in pharyngeal mucosa, in the pleural space, and in the lung and respiratory tract. And those two areas are most frequent. What this is showing you is a weighted tube that has gone down the left main stem bronchus and ended up in the pulmonary bed. So all of that background brought us to, what are we going to do about it? And with the leadership of Beth Lyman, who's on this webinar, the development of new opportunities for verification of enteral tube location, also known as the NOVEL project, that has been sponsored and well supported by the American Association of Enteral and Parenteral Nutrition, was born. We're a multi-professional, interorganizational alliance of individuals focused on a better understanding of NG tube placement and developing safety mechanisms around that. Current NOVEL membership is, we have representation from the American Society of Parenteral and Enteral Nutrition. We have from the American Association of Critical Care Nurses, Pediatric Gastroenterology and Nutrition Nurses, Child Health, Society of Pediatric Nurses, and we have a parent representative. And I want to highlight that this parent representative is one who lost her child to a misplaced NG tube after her child survived cardiac surgery in the neonatal period. So where do we start? What do we address? Blind placement is not a benign procedure. We all acknowledge that. Challenges are across the continuum of care. There's no standard in placement and verification, and the science is very limited, and it's for its efficiency and accuracy. And there are consequences for the patient, the family, the provider, for displaced or misplaced NG tube. So what did we do with that? We started out where science starts, what's in the literature. So in 2014, we published this paper that gave us an idea as to what was in the literature regarding NG tube placement and verification. We went on, once we found out what was in the literature, because we had no idea of what the denominator were. What are the numbers that we're dealing with? What are the methods that we're dealing with? So we did this study We had 63 participating facilities, and we did this study to find out exactly what that denominator was. And that's the study that I spoke to before, that we found out that 24% of all hospitalized children will require some type of nasogastric, orogastric, or post-pyloric tube during hospitalization, with 61% of them being neonates. We went on, we took from that and said, well, it's not just in hospitals. What's happening in home care management? So we looked at that, and we did a survey to look at exactly that, what is happening in home care. We had approximately 200 respondents from that. 75% of those acknowledged that they had long-term nasogastric tubes, and they were still using auscultation, with a lower percentage using gastric pH as a method to verify. From that, we were able to then begin to describe what are some recommendations for home use of pediatric nasogastric tubes, and how can that look in the home, and how does that look different from what is happening in the hospital. We kept going because there's so much work to do. And from all of that work, from collaborations and discussions and presentations of our group, we then were able to put together this paper that came out in 2018 about best practices for best practice recommendations from our novel project for nasogastric tube safety and placement verification. I'm happy to say that this paper has had more than 20 citations based on information that's in the Web of Science, and over 3,300 full text downloads. So this tells us that our work is not finished, and that this is information that providers are looking for. What do we do, and how do we do it? So as a good work group, we were able to provide some guidance from that paper. And this is an algorithm that I know Beth, myself, and other members of the novel project have received phone calls and have received emails from various people to say, how do I tailor this to what's going on in my institution? And so this is a guide for people to use. And then, like any good group, we had to go back and evaluate our progress and evaluate our impact. So there's a paper that was just recently accepted that does just that, an evaluation of methods related to information that the novel project has put out there, and it should be coming out soon. I will tell you the little tidbit from that is there were 245 respondents, and 38% of them still acknowledge that there are discrepancies within their institutions of how NG tubes are placed and placement verified. So what keeps us going? And what keeps it real? So I put here 3 quotes, one from a parent, and this is the parent that lost her child. She's become determined to find a better and safer method for feeding tube placement so that no other parent or person will have to experience the loss that she has. I can tell you that we have a lot of conversations with her, and it's been, I believe, 13 years now that she's lost her child. And she is a very vocal and active advocate for the work that we're doing to find a better way. From a nurse, and this is from a nurse that it was from that nurse's hands that a misplaced tube was placed and caused detriment to her patient. The moment that the patient went into respiratory distress, my whole life changed. So this just goes on to say that it can be detrimental. And from a provider, a clinician has 2 jobs: take care of patients and find better ways to take care of patients. So what's our future, and what's the novel project doing next? Ongoing investigations into current practice. What are we doing? How do we disseminate this knowledge that we learned from our investigations on nasogastric tube safety? How do we continue nurse, provider, and I should have up there administrative education, right, on nasogastric tube safety? And the development and evaluation of patient and family education and materials so that we can help them when they take their children home. And so with that, I will turn it back to our moderator and take questions that you may have related to these topics. Thank you so much for your attention.
Oh, and thank you, Dr. Gardner, Beth, and Dr. Irving for some great information. So that concludes the slide presentation portion of our program. And as Dr. Irving just mentioned, we'd like to begin our question and answer period. So we do already have a question, and it says, it asks, you mentioned ataxia telangiectasia, if I pronounce that correctly, and could you expand why this matters and how NG tube placement practice is affected? And I'll throw that out to the panelists. Yes.
Susan, I will
Leanne.
start. It's Lea Anne. And I did bring it up because in reviewing some of the reports, some of the staff said they were trying to avoid x-rays. That doesn't mean if a patient has this condition that you avoid it, but there definitely needs to be discussion, I think, with the provider, because these patients are at higher risk for cancer because of, it's a genetic disorder that makes them more susceptible to the negative effects of radiation. And my reason for bringing it up is in looking at the reports that we saw from Pennsylvania hospitals, there were many times where multiple reports had to be, or multiple x-rays had to be taken, and these were within individual reports where 2 or 3 x-rays were taken because they couldn't find the tip of the NG tube. It was not, see, because the chest x-ray didn't see the stomach, they couldn't find that. So the reason why I brought that up is just to keep in mind, especially if you have an individual and especially a child with this condition, taking multiple x-rays may not be the best thing, but I'm not recommending what should be done, just that it needs to be brought up to the provider who's overseeing that patient's care. And if Sharon or if, Beth, you have anything, please add.
If not, we're going to move on to another question. In your research, and again, this is for all the panelists, our expert panelists, in your research, have you come across anything on connecting NG tubes to suction for decompression without any verification methods? And please just jump in if you'd like to answer that question.
This is Lea Anne. When I was doing the research on this project for verification methods, I did not come across anywhere that says you can put in a larger bore tube for decompression. You still should verify where that tube is before using suction.
Okay. Beth or Sharon, any other comments? Okay, then we will go on to the, what's that?
I would agree with what Lea Anne said.
Oh, okay, great. Other than the litmus pH paper, is there any other way besides going to X-ray next?
So I'll do a stab with that. Yes, there absolutely is. For those of you that take care of adult patients, there is technology. And to be quite clear, I believe that technology is perhaps the best answer. And I don't mean an X-ray, but technology that gives you real-time visualization. There's a camera called the Iris camera. There is a product called the CoreTrack where you can see the tip of the tube as it moves down. There are other technologies in the pipeline. In pediatrics, we are limited by that, by not having that capability. But with adult patients, you do have capability other than pH or an X-ray.
Okay, great. I'll just move on to the next question. If the recommendation is to check placement every 4 hours, do you turn off tube feedings for 1 hour to check pH? And if this is the case, do you make adjustments in feeding rates for this?
So I'll take a stab at this one too. So
Okay.
the number of times that we need to check placement of an, an NG tube is not evidence-based. It is a bit of a sacred cow. I am not saying that it isn't a good idea to do it every 4 hours, but what I'm saying is that particularly when you have a patient getting continuous feeds, turning off the feeding and then turning it back on in 20 or 30 minutes, after you've checked the pH is a lot for nurses that have 4 or 5 patients apiece to be keeping track of, and perhaps more than one of their patients has an NG tube with continuous feeds. You can tape the tube in such a way at the nose or the cheek. We don't tape them at the nose, on the nose in pediatrics, so that you can see the centimeter mark. And if that centimeter mark is the same and the patient is otherwise stable clinically, then that can be a check. But turning a feeding off when it's continuously fed is a pretty hard thing for nurses to remember in 20 minutes, and how often does it stay off for 30 minutes or an hour or something like that. So that may not be terrifically realistic unless you have just 2 patients in an ICU, and that could even be. They have a lot going on in there too, for sure.
Okay, thank you. So the webinar will soon be ending, but we do have time for just a couple more questions. I'll read this, what was put in the chat here. It says, I didn't hear any discussion about high-risk patients who should require direct visualization for the tube placement, i.e. LOC. You know, if you guys could answer that or comment about that.
I'm not sure. Can you run that one again?
Sure. It just says, I didn't hear any discussion about high-risk patients who should require direct visualization for tube placement. So I guess they're asking if you can comment about that high-risk patient.
Okay. Well, and certainly, I definitely agree that a patient with decreased level of consciousness, someone that's in the ICU, paralyzed, things like that, the ability to do direct visualization via the iris camera or using a core tracker, something like that, is going to be very helpful, because if they have an endotracheal tube, it is puts them at higher risk for that tube to follow the ET tube down into the lung. And so I definitely do agree that if we can get direct visualization, that would be the ideal way to go. That is not typically, it's not been typically done on a high use basis, but I certainly support anything with direct visualization that tells you where that tip is going at the time it's going.
Okay, great. I want to thank everyone, including our 3 panelists, for joining us today. If you experienced any issues assessing the evaluation and our certificate of continuing education, please feel free to direct any inquiries to Shelley Meixel at shmixell@pa.gov. This concludes our webinar, and thank you again.